I think that we've now settled down on the genomic testing, the most important test being assessment of P53 status by deletion and by sequencing by mutation, as well as IgHV mutation status as being the two pillars of prognostic testing in CLL. There's a whole slew of other minor testing that we can do, but I think the IgHV and the P53 is important. Now, the story is kind of interesting because it is thought that with the novel therapies that we don't need to do this test anymore. But what's emerging in this Congress and in the last year or two suggests that may not be true, because it seems like for Venetoclax or Obinutuzumab that the mutation testing, the IgHV mutation status and P53 mutation status may still confer a inferior survival even when you get treated with Venetoclax or Obinutuzumab. And what we're seeing in this Congress is that even with the combination of Ibrutinib and Venetoclax, then maybe there's a difference in outcome between patients who are P53 mutant and not, and between those who are IgHV mutated and IgHV unmutated. And an interesting story is coming out in that patients who are IgHV unmutated are more likely to achieve MRD negativity with Ibrutinib Venetoclax. So this is a bit counterintuitive because this is a poor prognostic subset. But equally, even though they achieve MRD negativity more often, they may develop MRD and clinical relapse earlier once we cease therapy. So there's now a disconnect between MRD status and your progression-free survival with the novel therapy. So I think at the moment, what this tells me is that in this day and age, even though we're using novel agent predominant CLL, the IgHV mutation testing and P53 testing are still absolutely required.